name is Megan Emad, and I'm going to talk to you today about drug-drug interactions. Right. So some things we'll talk about, we'll go through some statistics, some risk factors for drug-drug interactions, how do we identify them, how effective are those tools, what are some examples of drug-drug interactions, and then some strategies we can use to reduce them. So why should we care? Drug-drug interactions, they're ubiquitous, they're harmful, and they're unique in that we cause them and they're entirely preventable. These are some statistics based on data from 2014 to 2015. Sorry, one second, having technical difficulties. Oh, weird. Cool. Sorry. So these stats are based on data from 2014 to 2015. I wasn't able to find more up-to-date numbers because there's been very few studies that have actually highlighted the exact figures related to drug interactions, but takeaway is that it is a big issue. These are some risk factors, some common reasons patients might be at increased risk for a drug interaction, with polypharmacy being the most notable among them. It's associated with an 80% risk of experiencing a drug-drug interaction. These are some of the tools we use to identify and prevent drug interactions. So basically the provider, our EHR drug interaction system, and then our pharmacists. And I wanted to explore primarily these first two. So I was especially curious how good are PCPs at recognizing drug-drug interactions. And I was able to find this study from 2018. It was a prospective cross-sectional study of drug interaction preventative care practices among PCPs in the US. And it enrolled 330 board certified family and internal medicine physicians. And presented them with 3 simulated patients who had symptoms of drug interactions. The simulated patients were taking one of 3 commonly prescribed medication classes, including opioids, CNS depressants, or antibiotics, in addition to common substances that could cause one or more drug interaction. So that included things like over-the-counter meds, food, alcohol, prescription meds, supplements. And then the physicians were scored on their ability to evaluate the patient, inquire about their meds, investigate for possible drug interactions, and provide treatment recommendations. So interestingly, in just over half the cases, 55.1%, physicians were able to correctly diagnose that what their patient's primary problem was. So like depression, palpitation, somnolence, but in only 15.3% of the cases, physicians were able to actually identify that it was a drug interaction causing that medical problem. And even less of the time were they able to identify the specific drug interaction, so 0.9%. And these findings aligned with prior literature, but actually suggested that the problem is worse than previously thought, because this was the first study that had complete data on the participants as well as a known diagnosis with the simulated patients. So drug-drug interaction specific treatment was provided 15% of the time, and of the physicians who recognized that there was a drug interaction, they only provided counseling 32.7% of the time. Other studies have shown that physicians only counsel patients on drug interactions and adverse reactions less than 25% of the time. So overall, PCPs in this study, they didn't recognize or adequately treat the drug-drug interactions. However, greater than 99% of them said that they used some kind of MedRec tool or practice, and nearly 75% said they used the EHR drug interaction software. So we're all familiar with the EHR drug alerts. It's essentially an interaction software that's a clinical decision support tool. It draws upon a database of knowledge to help us prevent drug interactions, harmful events. However, there are many that aren't helpful or necessary. And when these alerts are not properly filtered, they can stack up and contribute to alert fatigue and high override rates, and then subsequently or potentially patient harm. So alert fatigue, it's it's not just the drug alerts that we're having to cognitively manage. It's, Epic Inbox, Epic Chat, our pagers, our cell phones, Teams, Outlook. So there's a lot that we're cognitively burdened with, and we can easily become desensitized and override an alert that could be potentially harmful. I had difficulty finding a study that actually evaluated adverse events related to alert fatigue, but I did find that it has been implicated in some high profile errors. And this was one example of a pediatric resident at UCSF who accidentally gave a patient an extremely high dose of Bactrim, in large part because she'd been advised by colleagues to just ignore the alerts. And so this is a high override rates of drug alerts. It's a widespread problem. And there's been a number of studies that have shown this. And this was one study that looked at alert overrides over 1 year across 6 ICUs. They evaluated nearly 2,500 overridden alerts, and they found that 80% of the overrides were actually appropriately overridden, meaning there are about 500 alerts that were inappropriately overridden. And of those 500 alerts that were inappropriate overrides, they carried more risk of an adverse drug event. So this suggests that by suppressing alerts that are appropriately overridden, we could free up some cognitive space to hopefully recognize an inappropriate override and avoid adverse drug events. This was another study that looked at overridden high priority alerts in both the inpatient and outpatient setting at an academic center. And they looked at over 16,000 interaction alerts over the course of 1 year. And 98% of them were considered high priority alerts. And of those, over 95% of them were overridden. They then took a stratified random sample and determined that over 2/3 were considered appropriate overrides. Of the 16,000 drug-drug interaction alerts, 221 of them were of the highest severity, so medications that are absolute contraindications to each other. However, 87% of them were overridden, and they found that all were inappropriately overridden except for one. So this is obviously concerning, but the silver lining here is that 221 out of 16,000 is a very small number, so it's pretty rare that providers are actually trying to order these medications together. So the most common reason for the alert overrides in this study was no reason listed. And this was likely because providers were presented with too many alerts. And so instead of evaluating each one individually, they would just select override all. And this is what happened. So similar to the prior study, the data shows us that we need to improve the effectiveness and positive predictive value of these alert tools so that we can recognize high severity alerts and improve patient outcomes. And these are some changes that have been suggested to do that. Most importantly, reviewing alerts considered to be high priority and reclassifying them if they are not, and then suppressing those that are appropriately overridden to reduce alert burden. Another takeaway I had, we should just remember that these drug alert programs are tools, and we shouldn't expect them to save us from making mistakes. And nothing beats giving a thoughtful clinical review to our medications before we're prescribing. And so I want to talk through some examples together. You guys are probably familiar with a lot of these. I picked them mostly because of alerts that I've received in the last few years and just wanted to explore more of the evidence behind them. So first I want to talk about drug interactions that can cause serotonin syndrome. So serotonin toxicity, it can be caused by overdose of drugs or interaction between drugs. And hospitalization is actually extremely rare. And the majority of cases fall on the mild side of the spectrum. However, they're often unrecognized, underreported, or mistaken for other problems. That being said, what's great about the majority being on the mild side, if they're recognized, they can be managed with just simple medication changes. So in my research, I found this interesting clinical review published by the College of Family Physicians of Canada, and it was written by 4 PharmDs. And they highlighted that there's actually disagreement among experts on the list of implicated drugs in serotonin toxicity. So the list of serotonin drugs that have been published by the FDA and Health Canada includes drugs that are unlikely to cause toxicity based on their mechanisms of action. So either they don't actually act on the receptors that cause serotonin toxicity, or if they do, they're actually blocking the receptor, not activating it. Furthermore, there's a lack of case reports that implicate these medications. And of the few case reports that have implicated them, the evidence has been reviewed and been found to be poor quality. So in 2016, the FDA released a warning that said opioids could interact with triptans and cause toxicity. But it turns out that was based on poor quality case reports that did not use validated criteria. And then similarly, the FDA, Health Canada, and the World Health Organization released warnings about 5-HT3 antagonists causing serotonin toxicity, but that was also based on poor quality evidence. So what ended up happening with this controversial data is that inaccurate information was incorporated into our drug interaction software that's used in clinical settings. And the companies that own these interaction software have recognized that the FDA and Health Canada have published information based on weak evidence, but their interaction checkers will still flag combinations of drugs that are unlikely to cause serotonin toxicity. So this is an example from our EHR, and the meds outlined in green are a few of those listed on the recent slide that are unlikely to cause serotonin toxicity. So not only does this contribute to alert fatigue, but it can also lead to prescribers avoiding medications that could potentially be helpful for a patient. These are the medications that have evidence that has shown increased risk of serotonin toxicity, and this is an easy approach to prescribing that this group of pharmacists has recommended. So your group A is basically all the MAO inhibitors, and group B is all the SSRIs, all the SNRIs, and then the specific meds in each class. So you always want to avoid 2 from group A, or a group A and a group B. You want to use caution if you have 2 or more group B drugs, especially one at a high dose. And then just monitor closely if you have a patient who is on one group B drug and you're adding another one. Next, I want to talk about SSRIs and oral anticoagulants. So SSRIs inhibit platelet uptake of serotonin, which promotes platelet aggregation. Many studies, not all of them, but the majority of them in the past 15 to 20 years have shown that risk of major bleeding is higher with concomitant use of SSRIs and oral anticoagulants rather than oral anticoagulants on their own. I chose this study to talk about because it's new, it was just a couple months ago, and it was a large population-based case control study out of the UK. And they looked at a general practice database and evaluated 42,000 cases of patients who were on SSRIs, were diagnosed with AFib, and then started on an OAC, and subsequently had a major bleed that led to either hospitalization or death. And there were over 1 million controls. And essentially what they found at 5-year follow-up was that patients were 33% more likely to have a major bleed if they were on both classes of medications. Not surprisingly, risk was higher with those on warfarin. And then prior studies had suggested that higher potency SSRIs would increase the risk of bleeding, but this study did not show that, and also showed that there was no difference in risk between various types of bleeding. The incidence was 28 major bleeds in 1,000 people over the course of 1 year. And the absolute risk was on average 9 major bleeds in 1,000 people over the course of 1 year. So basically relative risk was 1/3 higher with concomitant SSRI use, but just as prior studies have shown, absolute risk of a major bleed is low. So in patients with strong indications for both drugs, the small absolute risk is probably acceptable. But if for some reason you had a patient who was, the indication for either drug was marginal, then maybe that excess risk would be something to think about and reconsider prescribing both at the same time. Next, I'd like to talk about calcium channel blockers and statins. So of the 7 statins, only 3 are metabolized by CYP3A4 in the liver: simvastatin, atorvastatin, and lovastatin. And if a calcium channel blocker is taken with either simvastatin or lovastatin, then it can inhibit that enzyme and increase the serum statin levels, increasing the risk for serum or statin toxicity like myopathy, liver toxicity, or rhabdo. Luckily, atorvastatin, which is much more commonly used, is less prone to interaction because of its structural properties. And so it's not actually shown any clinically significant interaction in trials, although there are a few case reports. So the American Heart Association has recommendations for statin dose reductions depending on the calcium channel blocker to reduce the risk of statin-related side effects. And it's just something to think about if you have patients who aren't tolerating more commonly used statins. Next, I want to talk about omeprazole and clopidogrel. So this is like a whole can of worms, but in 2009, the FDA issued a warning that omeprazole reduces the antiplatelet activity of clopidogrel by about 50% when given together or 12 hours apart. However, that warning was based on ex vivo data, and there has been no convincing evidence to support an important clinical drug-drug interaction between these 2 medications. It has been the focus of numerous non-randomized observational studies that have varied widely in their components, and that has essentially led to lots of largely conflicting data. This was the only randomized double-blind study that actually addressed the cardiovascular implications of the 2 medications, and it showed no difference in cardiovascular events between the 2 groups. However, GI events, so GI bleeding, was less in the group on omeprazole. Unfortunately, in addition to this study, a few limitations, the study was stopped early because the sponsor went bankrupt. So the absence of interaction between the 2 medications couldn't be considered a definitive finding. But all of this basically led the American Heart Association and the American College of Cardiology to base their guidelines on PPI use in patients on DAPT on the presence or absence of GI bleeding risk factors. So for patients on DAPT, PPI is recommended in those with a history of GI bleed. It should be considered in patients with risk factors for GI bleed, and it is not recommended for those at low risk. But you can see the level of evidence for all 3 of these recommendations is C. They actually don't specify what PPI, and this is the only time they mention omeprazole, and they essentially say it's up to the provider. So I think essentially what can appear to be an enzymatic reaction doesn't necessarily translate to like a clinically significant outcome. So rather than hanging our hat on non-randomized observational trials, we should, base our decisions on randomized clinical trials, better evidence. And I would say in this case, if you are really concerned, you could use pantoprazole, but otherwise there just isn't clear and consistent evidence for this interaction. Last, I want to talk about tamoxifen and antidepressants. So by inhibiting CYP2D6, the concentration of tamoxifen will be reduced. And that's because it prevents the conversion from its prodrug to its active form. So if you have a patient who is on tamoxifen for breast cancer, that could be a big issue. And these 4 antidepressants are inhibitors of CYP2D6, and therapy modification is recommended for all 4 of them. So some strategies to reduce drug-drug interactions, minimize the number of drugs prescribed, reevaluate therapy on a regular basis, always consider non-medication options, monitor for signs and symptoms of toxicity or effectiveness, adjust dosages or administration times. And then remember, you can always look for new interactions when you're prescribing. And in summary, so the EHR, as much as they can prevent us from causing harm, they can also kind of secondarily lead us to cause problems, and whether that's from alert fatigue or discouraging us from using medications that could actually provide useful for the patient. We should avoid and reduce polypharmacy as much as possible, and tell your pharmacist how much you appreciate them. Any questions? There's definitely a lot of literature on it, and there's a big push for it. Oh, yeah. So the question was if there's any effort to try to clean up the EHR software. And it sounds like there are a lot of people, I think probably more in the informatics side of things, that are probably working on this, but there is a big push for it. Absolutely. Most of those studies I looked at were actually pre-pandemic, but all the examples that I showed, like the pictures, those are still in our EHR system. So I don't know how much progress we're actually making. Cool. Thanks.
Did you?
I sent it to Eden. And I think it's on the, I sent it to his, as a OneDrive. It was big. I can resend it to you.
Yeah.
Do you want me to do that?
Yeah. Just because I don't know where it was. Oh, of course. Okay, now you have to give me access to it.
Oh, shit. Is it sending me an email?
Yeah, send you an email. You should.
don't give you access, then I don't have to present.
Right, that's true. Okay, thank you everyone for, while we get the file set up, but I present Dr. Sibbernsen here and
Thank
his
you.
presentation on healthcare made ridiculously simple.
Awesome, thank you. Hi, everyone, I'm Eric. I made this title in jest because it's impossible to present the US healthcare system in a ridiculously simple way. Also, 30 minutes is not nearly enough time to cover this topic, but I think it's the right amount of time because much longer and you'll glaze over and want to pull your hair out. My main inspiration for wanting to cover this topic is this question that I've been asked by patients dozens of times during my residency. Who's going to pay for this? Will my insurance cover this? This medication cost me $20 last time I picked it up, and now they want $1,000. When I was on geriatric service with Dr. George, we had a patient with a hip fracture, and we're offering our geriatric service, and the patient said, I don't want this service if it's going to cost me a penny out of pocket. And we couldn't really give her a definitive answer on whether or not it was going to cost her directly any money to have this service involved. And what we find a lot is that the patient in the room and the provider in the room are often the two people with the least amount of information about how much something costs or whether it's going to be covered or not. I think this might be partially intentional. And then also this New York Times investigative article that I read a year ago about our neighbors Providence Healthcare and how they use their nonprofit status to basically expand in more wealthy areas. And they also highlighted this Rev Up program where people were going into patients' rooms in the hospital to try to get them on payment plans. Oftentimes patients that were meant to be receiving discounted or free healthcare based on their nonprofit status. And you know, as we as the providers who are sitting across from a patient face to face, I think we have some responsibility to understand all of this better and be able to give better information to our patients when they're trying to make a medical decision. My main source for this presentation is the healthcare handbook. Dr. Shadaga recommended this to us. at her grand rounds earlier this year. It's a fantastic book. It actually is pretty accessible and easy to understand, despite the difficult topic. So I recommend everyone getting a copy and looking through this. I think we've all seen charts like this before, with the US healthcare being the most expensive in the world, and often towards the bottom of lists for things like life expectancy and infant mortality when we look at developed countries. Just a brief overview of kind of the healthcare landscape. So you can see on the left, inpatient stays are the most expensive part of the US healthcare system. And you can see different inpatient diagnoses and how frequent patients are admitted for these things and how much they cost, with septicemia being the largest in the top right. And then you can also see different organizations of our healthcare system through nonprofit, public government, and then not for-profit. HCA is kind of, everyone knows about HCA, and then church operated as well. And then I'm going into primary care, so I got to talk about primary care. If you look at this chart on the right, out of 1,000 people in the US every month, 800 will experience symptoms, 238 of which will be seen in a clinic. 8 will be hospitalized, and less than 1 in an academic medical center. So primary care really carries a large brunt of at least population of our healthcare system, and receives about 5 to 7% of healthcare spending. 1/3 of physicians in the US are in primary care, which is much lower compared to other developed countries. And you can see these ratios. In the US, we have 1 primary care doctor for every 3,300 people. And in Australia, it's 1 to 588. So we could certainly do better by increasing our primary care services. Next, I'll talk a little bit about insurance. Insurance uses a number of different utilization management tools to try to reduce their costs. These are things like requiring in-network providers, prior authorizations, which we're all familiar with. And then on the right is cost sharing. So we all have probably a vague understanding of how this works, but different insurance policies carry different deductibles and different copay amounts. And the idea behind this is that patients will have skin in the game and not overutilize healthcare, the healthcare system. There have been multiple studies that have looked at this by comparing people with lower and higher deductibles and lower and higher copays, and it doesn't really seem to correlate well with utilization. Furthermore, it's a lot to ask a patient to determine whether their abdominal pain is from gas or something life-threatening. So people tend to go to the hospital when they feel like they need to. Looking at the entire population, this is from 2019. You can see almost half of people are covered under an employee-sponsored insurance plan, then with Medicaid and Medicare making up the 2 other largest portions. And we'll talk more about uninsured later on. Medicare passed in 1965. I'm not going to spend too much time on this because Dr. Folger talked about it last Wednesday at the cost-conscious prescribing seminar. But just remember, Part A and Part B are inpatient and outpatient. Part D is prescription coverage. And then Part C is Medicare Advantage, where a private insurance company will take the money directly from Medicare and then distribute it through their insurance plan. And most people on Medicare in the US also carry supplemental insurance because Medicare often doesn't cover everything that they require. And then Medicaid. So if you look at the left, initially to qualify for Medicaid, you had to be below some percentage of the federal poverty level and be in one of these groups. So children, long-term disabilities, pregnant women. In 2014, the Affordable Care Act expanded Medicaid to apply to anyone with an income less than 138% of the federal poverty level. You can see the dark blue states on this map are states that, as of 2021, had opted out of the Medicaid expansion. And since in 2023, South Dakota and North Carolina actually opted in. But in how this looks is in California, since they accepted the federal funding from the Medicaid expansion, they have to offer Medicaid services to anyone that makes less than $38,295 a year. Whereas in Texas, who opted out, they set it at 14% of the federal poverty level. So it's only available to non-disabled, non-elderly adults that are making less than $3,885 annually. Private insurance is broken up into a number of different systems. The most common is a preferred provider organization, which is similar to what we have through Pacific Source, where we are encouraged to use in-network providers. Then there are high deductible health plans, which are usually coupled with flexible spending accounts and make up about 30% of the private insurance. And that's the most common used in the Affordable Care Act health insurance marketplace. And there's also HMO like Kaiser. Employee-sponsored insurance is unique to the United States. It kind of started after World War II when the government enacted a wage freeze on the country. So companies started offering insurance benefits as a way to entice employees. And that morphed into our current status where any company with more than 50 full-time employees has to offer employee-sponsored insurance. The quality of that health insurance varies widely based on what the company is. This is good for health insurance companies because they can sell a large policy to a large group of people. And because they're working, it improves their risk because usually it's healthier people working. It's good for employers because it's a hiring incentive and they don't pay taxes on the amount of money that they put towards insurance premiums. And then it's good for employees because you only pay 50 to 90% of your premium. The disadvantages of it, so as our healthcare costs have gone up in the United States, companies are having to devote more and more money towards people's health insurance, and this has led to wage stagnation, as you can see in this graph on the left, with wages being the light blue on the right, with little increase through these decades. The other issue is medical loss ratio. So medical loss ratio is the percentage of insurance premiums that go directly towards medical costs. The Affordable Care Act set medical loss ratio at 85% for insurance companies. So they have to get at least 85% of the premiums back to the population that they're insuring. However, a lot of insurance companies are not ACA compliant. And then the other big problem is insurance churn. So annually, 25% of low-income individuals will leave any given health insurance policy. So this disincentivizes these insurance companies from investing in chronic disease management and preventative health, basically betting on the fact that 25 or more % of the people under their policy will no longer be on their policy when they reach the more expensive end stages of any given disease process. And then looking at uninsured, so on this timeline on the left, you can see a big drop after 2014 when the Affordable Care Act was passed. And what I think is interesting is looking on the right, when we look at the uninsured non-elderly population in 2019, close to 75% of people have a full-time worker in the household. And then when you look at the family income, many people are well above hundreds to 400% of the federal poverty level. There's also a large portion of people that qualify for Medicaid who, for whatever reason, haven't signed up. It's a cumbersome process to get on. In 2017, there were $42 billion incurred from our uninsured population, and 20% of that was eaten by hospitals and providers. Clinics, and then 80% kind of bailed out through various government networks. So when I say it's expensive healthcare in the US, in 2020, it cost $4.3 trillion. That's more than the entire economy of every country in the world except for China and Japan. We also spend the highest percentage of our GDP on healthcare at 19.7%. The next highest is Switzerland at 11%. And we have a lot of high utilizers, so 5% of people account for almost half of our healthcare expenditures. And then on the left, you can see where the health dollars come from, so private insurance, Medicare, Medicaid. And then on the bottom, you can see where they go. As I mentioned, inpatient stays being the most expensive. Price transparency is a big problem, as I mentioned with my kind of initial motivation for this. So cost is the amount that it costs for any given clinic or hospital to keep the lights on, pay salaries, and supplies. The charge is what that system charges to the insurance or the individual, and reimbursement is how much they get back. And none of these numbers make any sense when you look at them. In this graph, you can see, so the dark blue at the bottom is Medicare reimbursement rates, which are readjusted and set on an annual or even shorter scale. And then in gray, you can see what hospitals charged for each one of these things: an inpatient stay, a hip replacement. This was averaged over, I think, 28% of insurance claims. This data is from 2011, so it's a little old, but I doubt it's changed much. And then in maroon, you can see what was actually paid back to the hospital. And I think this is kind of where you end up with things like Dr. Menken's $12 bag to carry his stuff home. It's not a lot of rhyme or reason to it. I'm not going to spend too much time on reimbursement because it's kind of boring, but it's a very complicated system, and we're all familiar with the CPT codes, which are set by the American Medical Association and determine a service, which can be a procedure or time-based, and then our ICD codes, which are made by the World Health Organization. And then insurance companies look at the CPT code and the ICD code and determine if they're congruent, they'll pay it. If it's not congruent, they won't. And when I was on my grit rotation with Dr. Abraham recently, she mentioned that insurance companies are starting to use AI to scan through our notes to look for errors in coding and determining whether or not they need to pay out. For inpatient stays, we have the DRGs, which Medicare sets, and this is where the cost-conscious ordering kind of comes in. So Medicare, at the end of a hospital stay, determines what the complexity of it was, and they pay a certain amount based on that. So any extra ordering of tests and things that we do during that stay can kind of eat into that bottom line. And then we have the RVU system for outpatient. Then there's a lot of alternative pay models, which are being pushed by Medicare and Medicaid to try to focus less on fee-for-service model and more on a quality metric model. What this is looking like in practice is that most places have some combination of a fee-for-service and then bonuses on top of the alternative pay model. Insurance reimbursement is one of the big reasons why these price transparency isn't a thing. I think, as most of us know, earlier this year, Legacy and Blue Cross were in negotiations and kind of reached an impasse. I saw a patient in clinic a few months ago who was having kind of standard chronic cough for 2 months, but also had some lymphadenopathy. So we ordered a CT scan. And then when I followed up on her a couple months later, because I'd never saw the CT scan, I saw that she was admitted at Good Samaritan, the new diagnosis of metastatic lung cancer. And I asked her primary care provider, who's one of our attendings, kind of what happened, why didn't she get the CT scan? And she had Blue Cross Blue Shield insurance during this time and was concerned that it wasn't going to get paid for to get the CT scan. So all this to say, these negotiations have real impact on us as providers and then on our patients as well. These negotiations are the reason that one given procedure can be charged such variable amounts between different systems in different areas. Even within the same hospital, different insurances will negotiate different reimbursement rates and discounts. So getting the same procedure on 2 different insurances can vary widely. The other thing I think is funny is GoodRx. Whenever I look at it, I don't know any other products where you can go to Fred Meyer and it costs $809 and go to Target and it's $43. And also looking at these retail amounts ranging anywhere from $450 to $2,600. This is for the same medication for the same amount of pills. And this is because pharmaceutical companies are also negotiating their reimbursement and charges. Pharmacy benefits managers are kind of one of the boogeymen of the US healthcare system. Anyone who's seen Hassan Minaj's show, Patriot Act, kind of covered this a few years ago. But if you look on this chart on the left, for a theoretical medication that costs $17 to manufacture, by the time it's gone through all of these pass-offs, we reach $100. And PBM's main job is to negotiate charges and reimbursements with insurance companies and retail pharmacies, and carries a large administrative cost. Some people may have seen this graph on the left, which is growth of physicians versus administrators, kind of starting after the passing of Medicare and Medicaid. And you can see the administration growing exponentially as we need more people to figure out what these diagnosis codes are and what's reimbursed. We also have some of the highest administrative costs through insurance of any developed country, as you can see on the right. So what we're left with is a bunch of competing interests. These are return on capital in 2017 for each one of these groups: pharmacies, drug wholesalers, health insurance, pharma companies, tech and device companies. And everyone is negotiating to try to get the best deal for themselves. Oftentimes, the patient isn't necessarily involved in a lot of these, which requires some government regulation to control. And in the US, we have a very decentralized system. So as I was working on this presentation, it kind of reminded me of when my friends and I built a tree house when I was in middle school. We just kind of started nailing boards to a tree without any plan of what we were going to do. And we're left with something that looks like this tree house on the right. The point being, if you don't have a plan of what you're building, it's hard to build something structurally sound. There's very little policy that applies to all hospitals and all systems. It's more of a patchwork through these various systems and regulations. Oops. Next, I'm going to talk just a little bit about healthcare policy. So this chart is pretty self-explanatory, but you have a lot of competing interests trying to work with Congress, who is working with the executive branch to pass laws. I'm not going to go through this, but this is just a list of some of the major US healthcare reforms that have been passed through the years. The ones I've highlighted in red are all the instances where there have been big pushes to enact a national health insurance and it's failed. You can see the Affordable Care Act down there on the right, a lot of which was dismantled in the following presidential term. So is there another way? There certainly is. Universal coverage is talked about a lot. That's the goal of getting our uninsured down to zero. There's various ways that other countries manage this. There's socialized medicine, where the government controls both financing and delivery of care, which is like the NHS in England or our VA system. There's single payer models where the government provides the financing, but private hospitals carry out the delivery of care, which is what our US Medicare system is. And then there are public options where there's some mix of government and private financing and more regulation on the part of the insurance companies. Public opinion on this has varied greatly over the years. So if you look on the right, 56% of people favor a national health plan or Medicare for all. But when you start looking into at what cost, people are more resistant. So require most Americans to pay more in taxes, 60% oppose, or threaten the current Medicare program, 60% oppose. And everyone's worried about a national insurance plan leading to delays in treatments. I'll just do a quick slide on Switzerland. It's often pointed to as a role model that we could potentially move toward. It's still the most expensive healthcare in Europe at 11.4% of their GDP, but you'll find it high on every list of innovation and quality of care delivered. They have universal healthcare through compulsory insurance, private insurance. So there's no government insurance in Switzerland, but the insurance companies are heavily regulated by their government. So it's based on your income. Insurance companies can only offer a set amount, and that cost, charge, and reimbursement is all heavily regulated as well. And as a benefit, their physicians make on par or more than physicians in the United States. Here's a photo of us from the Physician Advocacy Day in Salem from earlier this year. It was really fun talking to local representatives about some of these issues. And I'd encourage everyone to be involved in this and keep track of what's happening in the news for healthcare reform as it's coming down. At the end of the day, as I mentioned, we're the people sitting across from patients, and we have a responsibility to understand this stuff. I recently did 2 weeks of outpatient pharmacy with Chris Blem, and I was really impressed by his knowledge and ability to get patients medications. He knew a lot of kind of different ways to order things and different ways to encourage patients to find discounts so that they could afford their medications. And it's something I want to carry on as I move forward. Once more, this is just one more push for the healthcare handbook. And finally, any questions?